Okay, I think that we can also start the meeting. I see just we're admitting all the other participants to the meeting. Hello, good morning, everyone. Okay. Okay, I think that everyone is there. Then we can start. First of all, I just want to recall that we are recording this video because we had so many requests to join this event and the system cannot host more than 120 people. Then we had to record the event and will be shared on Health First Europe website. Then, thank you so much to all the great speakers that today took the time to join our event about surgical site infection prevention. And a really important day because today is the 17th of November, then is the day before the European Antibiotic Awareness Day. I'd like to really kick off the meeting, giving the floor to Health First Europe President, Roberto Bertolini. Thank you, Roberto. Roberto, can you unmute yourself?
Yeah.
Okay.
You hear me now? Okay.
Yeah.
Good afternoon to everybody and welcome to this meeting on Health First Europe. It's a very strange situation. We are used to meet in person and to exchange views and network during the intervals and take a coffee, but I mean, these times are not possible these days. So then we need to, to communicate remote and, use these very brilliant platforms which have changed our life during the epidemic. So I hope we will be able to meet soon again in person and to enjoy networking and interaction. Health First Europe, since its first creation in 2006, has been working on patient safety and quality of care in order to bring these issues on the political debate. And we have been proactively involved in the European discussion on the Council recommendation of the 9th of June 2009 on patient safety, including the prevention and control of healthcare-associated infections. And we have enriched the debate on antimicrobial resistance with our approach, which is summarized in a very simple statement: preventing infection is the best way to treat infections. Now, in line with this approach, in May 2019, Health First Europe launched a pan-European survey to assess the current level of application of the global guidelines of WHO for the prevention of surgical site infection. The document was of 2016, and address the disparities between evidence and practice in the prevention of this important public health problem. The results of the survey have been collected in an insight report, which Health First Europe is delighted to launch to this occasion today. In this report, we collate the results of a pan-European surveys, which is commented by national experts, to raise awareness and attention of the European policymakers on the need to harmonize guidelines and protocols to prevent surgical site infections. This is an issue that regards surgical site infections, SSI, but also regards a number of other issues like vaccination protocols, strategies to address public health threats in general. So I think this issue is a sort of prototype that we can use to work on the homogenization of different approaches throughout the European Union and the European Union countries. Today, this virtual roundtable is an opportunity to bring together high-level speakers from WHO, the ACDC, country-level experts, EU stakeholders, and this discussion will allow us to address current gaps on the implementation of WHO guidelines on SSI and provide useful political recommendations to prevent and manage SSI and contribute to curb AMR, antimicrobial resistance, and ultimately enhance patient safety in Europe. SSI pose a threat to the lives of millions of patients every year, leading to over 16,000 deaths, increased patient morbidity, mortality, and loss of earnings during recovery are some of the indirect costs associated with SSI. And the overall cost of SSI in Europe is estimated to be around 19 billion euros. So it's a significant cost for the health and for the system in general. Moreover, the issues of antimicrobial resistance and SSI are part of the same vicious circle. As any healthcare-associated infections, SSI are often caused by antibiotic-resistant organisms, and the treatment therefore becomes very complex and challenging due to the antibiotic resistance, which is actually increasing, as you know, in many areas and with many pathogens. These factors all stress the importance of prevention of SSI in all patients across Europe. Prevention should aim at protecting and promoting patient safety while decreasing the burden of infection, especially in relation to the antimicrobial resistant bacteria. The good news is that SSI is largely preventable and avoidable. Up to 50% can generally be prevented through the successful implementation of clinical practice guidelines. If the necessary actions are taken, and sometimes they are simple actions, the threat of drug-resistant infections will be minimized, resulting in millions of lives saved. Therefore, to prevent and manage infections across the surgical pathway, it's necessary to implement a holistic and multi-level strategy. This should include system change, improving guidelines adherence, training of physicians, of personnel, education, monitoring, surveillance, evaluation to check where the problems are, and communications for awareness raising. Today's discussion will represent the occasion to address how to make the change happen and to facilitate this change of best practices to reduce the gaps between evidence and practice and ultimately save lives. Before we go on, I would like to give the floor to Mr. István Ujjeli of Hungary, who kindly accepted to virtually host the debate. So, Mr. Ujjeli, you have the floor, please.
Thank you so much, ladies and gentlemen, dear President Bertolini, dear Dominic Monet, dear professors. First of all, on behalf of myself and on behalf of my family, I would like to send to all of you my thanks in these days when you fight against the COVID-19 and you serve our societies. I think as member of the European Parliament, this is my main job this time, to tell you it's a really, really big job what you do. And as son of two doctors, my parents are doctors, I really know what does it mean to serve the society in these days. Secondly, I need to thank the opportunity to be together with you in this important roundtable program and be part of the introduction of the Insight report of surgical site infections. I want to thank the amazing job of Health First Europe. This great 16 years old alliance has already reached many aims in promoting and building truly patient-centered healthcare systems in Europe. This new Insight report collates the results of a pan-European survey commented by national experts to raise national and European policymakers' attention on the need to harmonize guidelines and protocols to prevent surgical site infections. Dear colleagues, if I can tell it, you have to know that, as I mentioned, my parents were doctors, so the healthcare was part of my day-to-day life. And with that, it's important to say that I'm not a health professional, I'm only a politician. But as a politician who is deeply committed to improving healthcare and improving patient safety. That's why I have started with some colleagues to create a framework of quality standards in European healthcare. And that's why we have put the strategic concept of the European Health Union on the table of the European Commission. I know very well it's not the most charming thing when a politician praises himself, but I'm truly proud that my proposal became an important building block of the Commission's new health program, and perhaps we can make an important revolutionary progress with it. And I could not have achieved it, we could not have achieved it without the support of healthcare NGOs and their professionals here in Hungary and also on the European level. So thank you so much, and we have made a huge step forward together. Ladies and gentlemen, the right to physical and mental health is a fundamental human right. According to that, improving patient safety and quality of care is a basic duty. I truly agree with those who are saying that improving patient safety and quality of care should be the main object of any national and European health policy. Therefore, preventing infection and tackling AMR are key actions which require immediate attention and intervention. Healthcare-associated infections are the most frequent adverse event during care delivery and the threat to patient safety. Despite all the efforts put in place by European hospitals to prevent HAIs, on any given day, about 80,000 patients have at least one HAI. It means that 1 in 18 patients in a European hospital has a healthcare-associated infection. For me, as a politician, it was shocking that regarding the official data, there are approximately 8.9 million infections each year in EU healthcare settings, and the HAIs can be responsible for approximately 37,000 deaths in European healthcare. And the HAIs cause not only human suffering, but also economic burden. The annual financial losses due to unsafe care and the infections are estimated at approximately 21 billion euros. We know that HAI is preventable. Effective infection prevention and control programs can lead to more than 30% reduction in HAI's rate worldwide. So we have a lot more to do. The European Parliament report on EU for Health calls the European Commission is develop new guidelines on patient safety and promote investment in modernizing health systems to overcome and reduce to minimum the health care associated infections and to support the fight against antimicrobial resistance. We are looking with great interest at Commission's proposal to strengthen the EU's health security framework and to reinforce the crisis preparedness and response role of key EU agencies, the European Medicines Agency, the ECDC, and the new EU agency, the Health Emergency Response Authority. These were the first pillars, the first steps in the pathway of implementing the concept of the European Health Union, but we have a lot more to do. I strongly believe that inequities and inequalities in healthcare systems and the resulting health disparities must be addressed. I strongly believe that it's intolerable that a European citizen could get 3 times more likely an HAIs in Hungary than an equal European citizen, for example, in Germany. Let's say, without strong healthcare systems, there aren't patient safety. Without quality standards, there aren't strong healthcare systems. In July, the European Parliament has adopted with a large majority the resolution of EU's public health strategy post-COVID-19. And among others, it includes that we call on the Commission to propose a directive on minimum standards for quality healthcare based on the findings of stress tests. As a committed politician in healthcare, I promise that I will push the European decision makers till we reach our goal: less HAIs, more patient safety, because health is an investment in human capital, in social and economic development, which contributes significantly to the protection of human rights and human dignity. Ladies and gentlemen, at the end, I need to thank again the amazing work of the team of Health First Europe, including Melina, Lucia, and Danica. Thank you so much. And now I'm delighted to give the floor to our experts, speakers, and I really look forward to understand how to implement a holistic and multi-level strategy, and what is the role that we as European policy makers can play. Thank you so much, and it was very honorable for me to be together with you. I will tell it to my mom.
Thank you so much. Thank you so much for your nice word. Now I will give the floor to Dr. Dominique Monet from the CDC.
Thank you, Melina, and thank you for Health Europe for this opportunity. So, dear Dr. Bertolini, dear Dr. Yei, dear colleagues, dear participants, thank you for this invitation and for giving ECDC the opportunity to open this virtual roundtable focusing on surgical site infections and antimicrobial resistance. As it was just reminded, tomorrow we will celebrate European Antibiotic Awareness Day. This will be the 13th European Antibiotic Awareness Day. And we would have thought 12 years ago when we started, with the support of the European Parliament, and in particular a former member of European Parliament, John Bowis, and of the European Commission, that 12 years later we will be there. And there will be a European Antibiotic Awareness Day, and there would be a World Antimicrobial Awareness Week. Because of the ongoing COVID-19 pandemic, this year's European Antibiotic Awareness Day will be a digital campaign with a focus on social media, as well as videos from key European actors. And we invite you to participate in European Antibiotic Awareness Day from your usual social media channels and to visit the ECDC website. As usual, ECDC will release its annual update on antimicrobial consumption and antimicrobial resistance surveillance with 2019 data. For antimicrobial consumption, these 2019 data from the European Surveillance of Antimicrobial Consumption Network, ESACnet, confirm the large variation among countries, both in the community outside of hospitals and in the hospital sector, and for different groups of antimicrobials. In general, we didn't see significant trends for the EU overall, with the notable exception of the polymyxins, of the consumption of one main antibiotic, which is colistin in the hospital sector, which increased between 2010 and 2019. This is a last line group of antibiotics, and this actually of concern. When considered individually, many countries showed either an increase or a decrease in antimicrobial consumption during 2010-2019, both overall and for specific groups or class of antibiotics, and this may reflect different policy initiatives and interventions at national level. So this is a mixed picture that would require further analysis. Still, one interesting finding is that the consumption of certain group of broad-spectrum antibiotics has been decreasing in recent years. One ECDC study that was published in Eurosurveillance last year showed that the trends in consumption of such group of broad-spectrum antibiotics and related resistance in bacteria commonly responsible for infections such as Escherichia coli, Klebsiella pneumoniae, these rates of resistance were decreasing, or at least stopped increasing in recent years. And we see it as the first signal that our joint efforts in the EU and in the member states, and these include also the momentum created by European Antibiotic Awareness Day, that these efforts are starting to show results. Nevertheless, antimicrobial resistance remains a serious challenge for the EU, as shown in the latest report from EARSnet, the European Antimicrobial Resistance Surveillance Network. Overall, for the EU, the percentage of resistance to vancomycin, and this is a last-line antibiotics which is used to treat patients with infections when other antibiotics do not work because the bacterium is resistant to multiple drugs. So resistant to vancomycin in a bacterium called Enterococcus faecium that is responsible for bloodstream infections but also surgical site infections, almost doubled since 2015. And in bloodstream infection, it's now 18%. And this represents a new challenge. Resistance to carbapenems, which is another group of last-line antibiotics, remains a concern. Several countries report carbapenem-resistant percentages above 10% for Klebsiella pneumoniae bloodstream infection. And it's also common in Pseudomonas aeruginosa and Acinetobacter species, two types of bacteria that are responsible for healthcare-associated infections, and at much higher percentage, for example, than in the Klebsiella pneumoniae. If we focus on Acinetobacter, in an article in Eurosurveillance last Thursday, we highlighted the national surveillance and the containment of carbapenem-resistant Acinetobacter baumannii in Europe, and they vary considerably among countries. Only 23 countries of the 37 European countries that participated in the survey had a surveillance system for reporting those carbapenem-resistant Acinetobacter baumannii. Only 15 had national recommendations or guidelines for its control, and only 8 countries had a national plan for containment, only one of which was among the 7 countries that reported an endemic situation for this type of bacteria. So there's definitely more work to do. The European Antibiotic Awareness Day digital campaign that ECDC will be launching tomorrow is one of the many steps needed to further raise awareness of these issues among health professionals and all Europeans in general. Last year, ECDC published the results of its first survey of healthcare workers' knowledge, attitudes, behaviors on antibiotics, antibiotic use, and antibiotic resistance. The study showed that knowledge and awareness of these issues was generally high among European healthcare workers, and higher than, as expected, higher than in. But it also highlighted important knowledge gaps. For example, among healthcare workers with direct patient or public involvement, direct patient contact or public involvement, 1/4 reported that they do not have easy access to guidance on infection management. And 33% replied that they do not have easy access to materials for advice on prudent antibiotic use and on antibiotic resistance. As a follow-up to a survey, ECDC will release tomorrow an animation video targeting healthcare professionals and highlighting what they can do to fight antimicrobial resistance. This video is provided with subtitles in all EU official languages, and we hope that it will be shown in hospitals and other healthcare settings throughout the EU. In addition, ECDC is providing listings of guidance and recommendation, including for the prevention of surgical site infections from the ECDC directory of online resources. Antimicrobial resistance remains one of the biggest threats to public health today and a challenge for Europe. We need efforts to further reduce unnecessary antibiotic use and to improve infection prevention control practices if we want to significantly reduce antimicrobial resistance, including in surgical patients. In an ECDC point prevalence survey in European acute care hospitals in 2016 and 2017, about half of antibody courses for perioperative prophylaxis lasted more than 1 day, with large variations between countries. When we around the table today know that we have scientific evidence that for most types of intervention, prophylaxis should not last longer than the duration of the intervention. At the end of today's roundtable, my colleague Tommy Shepke will present how ECDC, in collaboration with member states, is performing active surveillance of surgical site infection and now starts monitoring the implementation of prevention measures as part of the European surveillance. Finally, we're all asking ourselves the question about whether the COVID-19 pandemic will result in increasing antimicrobial resistance. And while the initial intuitive answer may be yes, the short review that we published last Thursday in Eurosurveillance provided a more balanced picture. There are about the same number of factors that may, in the end, result in increasing antimicrobial resistance because of the COVID-19 pandemic than factors that actually may result in decreasing antimicrobial resistance. For example, the fact that many planned surgical interventions were postponed resulted in fewer antibody courses for perioperative prophylaxis and certainly decreased antibody pressure and possibly antimicrobial resistance in the corresponding wards and hospitals. The truth is that we don't know about the impact of the COVID pandemic on antimicrobial resistance, and it will only become clear in the coming months and years as surveillance data and studies gradually become available. The COVID-19 pandemic reminds us that compliance with infection prevention control measures is critical to ensure the safety of hospitalized patients. Most infection prevention control measures that are essential for controlling the spread of the coronavirus also contribute to reducing the spread of antimicrobial resistant bacteria. These, together with antimicrobial stewardship programs, must be maintained and strengthened. In the midst of the COVID-19 pandemic, we must not give up on our efforts to prevent and control antimicrobial resistance and must stay united to preserve the effectiveness of antimicrobials. Thank you again for giving us this opportunity. I hope that the roundtable will be successful and look forward to the presentation and to participating in the debate. Thank you for your attention.
Okay, thank you so much, Dr. Dominique Monet. Now I would like to really move toward more the national level and have a sort of overview what's the situation at the national level. Then I'd like to give, first of all, the floor to Professor Beckenstein from Germany.
Thank you very much. Thank you, Melina. Thank you for giving me this opportunity and inviting me on behalf of Health First Europe. And I'd like to thank Dr. Bertolini and the member of the European Parliament, Istvan Ujili, and also Dr. Dominique Monet for his nice introductory words. Now, I will try to share my screen if I find this here. This should be done.
It's the green icon.
And well, it has many, many things here. Let's see the desktop one. All right. You can't see, can you? Well, what do we have here? Maybe it's better if you have my presentation.
Yes, I can share your presentation, no problem.
Can you see this now? Do you see my because I have, you don't see this, do you?
Not yet, but I can share it, no worries.
If you would share it, please.
Yes. Second.
Because time is of essence and sparse, and we're a little bit behind already, 15 minutes, but I can't make up that time. So
no, but it's fine, no worries. Then share.
Yeah, that's what I tried, the sharing, but it didn't work.
Okay, because I'm trying to share. Where it is PowerPoint. Prova tu. Just 1 second. Non ci riesco.
No, I can't. I can't get it. I
No,
can't
no, but
do
we
it.
are sharing it. Okay. Now, okay.
Well,
Now
thank
we
you
should
very
be there.
much.
Yes.
Thank you. Thank you very much. If you could put this in presentation, well, thank you very much.
Okay, perfect.
So I was asked to give, from the perspective of the national representative, an overview of surgical site infection prevention and the current situation at the national level in Germany. If you could forward, please. So the questions that I was posed are: what guidelines or protocols are applied to prevent or reduce surgical site infections in Germany, and what are the main what are the main barriers to reduce the incidence of surgical site infections in Germany? So if you would forward, please. Right. Okay. So I do have here given for you a table of a recent publication from last year that was put together from authors from the Charité in Germany. And they looked at the annual burden per 100,000 population of 5 types of healthcare-associated infections in the German point prevalence sample, and also a German convenience sample, which is a considerable number of institutions, and compared this to the ECDC PPS sample. Now, when you look at the column here, I hope you can see my cursor. This depicts the SSI, and you can see that the health-associated infections, specifically surgical site infections, amounted to 115 per 100,000 population, which is indeed comparable and not very much higher than for the ECDC data. Looking at attributable deaths, it's 2.9 versus 2.6 in the ECDC sample. And looking at the disability adjusted life years, you see that DALYs per 100,000 would amount to 35.7 for Germany for the point prevalence incidence, and for the ECDC sample, this was 35.1 over the EU as a whole. So really, it looks as if there might be a little bit more, but not considerably more. If we could now move to the next slide, please. I'm representing as president for the year 2020 and 2021, the German Society for General and Visceral Surgery, which is a scientific society that was founded in 1998. It is currently more than 5,600 active members, mainly hospital-based surgeons. We have certified 400 centers, amongst them the biggest being for hernia surgery and bariatric surgery. And we've started a quality offensive by monitoring of surgical procedures with mandatory registration of procedures, structure, and outcome for certified centers. A couple of years ago, a working group of infections in general visceral surgery, which is headed by Drs. Meyer and Ekman, who are co-authors for this presentation, was founded. And with this working group, an initiative to reduce the inappropriate antibiotic use in surgery was started. Please advance. Next, please. So in Germany, to develop guidelines, we have a society that combines all the societies, which is the AWMF. So all the medical scientific societies gather under this roof and develop guidelines, interdisciplinary guidelines. So when we look at surgical site infection, really there are 162 hits, but no independent guideline. So there's no uniform guideline by this body of guidance. Next, please. However, the Robert Koch Institute, which is the government central scientific institution in the field of biomedicine, is one of the most important bodies for safeguarding public health in Germany. Its tasks are, and I've taken this from the website of the Robert Koch Institute, it's the identification, surveillance, and prevention of diseases, especially infectious disease. It monitors and analyzes long-term public health trends in Germany. It does epidemiological and medical analyses, provides a scientific basis for health-related political decision-making, informs political decision-makers, has executive tasks defined by special laws, and is responsible for federal health reporting. The next one, please. Now, the Robert Koch Institute, after this brief introduction, has 2 years ago published recommendations for prevention of surgical site infections. And this is the screenshot from the original publication with a reference. Now, this is in German language. But basically, it goes along very much with the WHO recommendations for prevention of SSI that were published in The Lancet a couple of years ago and that were referred to earlier. Next one, please. So regarding our own Society of General and Visceral Surgery, in 2014, we had recommended to implement a stewardship team, that the administration of the perioperative prophylaxis should be done by the anesthetist. It should be timed correctly. That is 60 minutes until shortly before the incision. It should only be given as a single shot, a second dose according to half-life of the drug or blood loss, which would be approximately after 3 to 4 hours. And post-operative prophylaxis beyond skin closure is certainly not recommended. So we have tried to move things forward then. And the next one, please. And here I took the liberty to quote from the ECDC data. Dr. Monet, I'm glad you didn't recur to this one, which came out last year and showed healthcare-associated infections, specifically surgical site infections, as percentage and incidence density in EU countries as of 2017. Now, when we look at the third line from above, in Germany, there were more than 1,800 operations with 1% SSIs per 100 operations, and the number of operations with known discharge dates was a little bit less, and the number of in-hospital SSIs was 31%. And this does not really it is a little bit better than looking at EU overall, because the percentage of SSIs there was 1.5, whereas the number of in-hospital SSIs also, it's a little bit higher when one looks at percent of all SSIs. So this may be probably because in Germany we have comparatively more hospital beds than in other European countries. Next one, please. Next slide. So specifically looking at our own efforts with the German Association for General and Visceral Surgery, I told you earlier about the quality registries that we've done. And one of the analyses that emanated from this one is a very recent publication from this year, where registries, the German Association for General and Visceral Surgery registry, which is called StuDoc, was compared with registries in the United States, specifically the NISQIP, and registries in Netherlands and Sweden. And when one looks at surgical site infections, this was in this high-risk group of patients with pancreatic surgery. It was 11.7% in Germany compared to 10.3% in the United States, which is comparable. However, in the Netherlands and Sweden, this was half the number. So the relative largest difference was 2.4, with the absolute difference being 6.8. However, when one looks at life-threatening health-associated infections like the pneumonias, they were fewer in the United States with 3.9 compared to Germany with 7.0, but in Sweden there were more. So it's difficult to look at this. The fistula rate, the pancreatic fistula rate, which often goes along with deep site infections, surgical site infections, grade 3, which can result in life-threatening sepsis, were pretty much comparable. So it's difficult to look at where we stand from a national perspective. Next one, please. So one thing I would like to draw your attention to is a very interesting analysis that was done, again, from Dr. Gastmeier and co-workers from the Charité and published last year, looking at 17 years data from hospital infection surveillance with this convenient sample of hospitals that record the events. And what you can see here is the association of climatic factors with rates of surgical site infections. Now, depicted here is surgical site infections A1, so these are really the superficial ones. And what you can see is the different histograms for all SSIs, for those without pathogen, those with pathogens in the middle, those with gram-positive pathogens, and those with gram-negative pathogens. And this is, the different histograms reflect different ambient temperature outside the hospital. So this is taken from weather charts. And you can see this with really in all the groups here, there is an incremental rise with the ambient temperature. So I think this is perhaps something which is at the moment underestimated. This is the risk that global warming will have on the risk of development of surgical site infections. So to wrap things up, after 10 minutes, a little bit more than I had. Next one, please, last slide. There are conflicting data regarding the incidence of SSIs in Germany compared to the EU. I strongly believe that there is no lack of evidence-based recommendations, be they from the WHO, be they from the Robert Koch Institute, the Krinko, or the ones that you will release today, which I've had the privilege to look at earlier. I think these are very good and very recommendable. But what we are really forcing is an uphill struggle like the legendary Sisyphus, where we have to roll this big rock up on the hill and it keeps coming down again. So implementation and compliance with existing guidelines is an uphill struggle. I think that from a national perspective, since I was asked to give this, reduction of hospital beds and shortening of inpatient stay may play a role for Germany. And finally, again, I think often in the literature it's underestimated that global warming may be a risk factor for SSI in the future. Thank you very much for your time and attention.
Thank you so much for this really comprehensive presentation. And I'm sure that later on there will be some questions for you from our audience. Now I'd like to give the floor to Massimo Sartelli, who will give an overview of the situation in Italy. Massimo, yes, you are ready.
Okay, thank you. Thank you very much for the invitation, Melina. I will share the video.
Okay, I see the agenda.
A moment.
Yeah. Okay.
Thank you very much for the invitation. I will speak about the Italian aspects in the prevention of surgical site infections. But when we speak about surgical site infections and the prevention of surgical site infection, we should speak to Italian clinicians, to European clinicians, and to the clinicians worldwide. Something about the Italian situation. This is a paper published in 1999 by Alessandro Cassini and the CDC about attributable deaths and disability at just life years caused by infections with antibiotic-resistant bacteria. In this paper, Italy and Greece have the greatest burden of infections due to antibiotic-resistant bacteria. Even if one considers its large and aging population, it is notable that about a third of the deaths due to infections with antibiotic-resistant bacteria in Europe were in Italy. In 2017, SCDC published a country visit to Italy to discuss antimicrobial resistance issues. These are the conclusions of the report, and the report summarized visits and meetings of SCDC. The CDC experts, Dominic Monet, Alessandro Cassini, Giovanni Mancarelli, noted the following aspects in Italy. Little sense of urgency about the current antimicrobial resistance situation from most stakeholders, and a tendency by many stakeholders to avoid taking charge of the problem. Lack of institutional support at the national, regional, and local level, lack of professional leadership at each level, lack of accountability at each level, lack of coordination of the activities between and within levels. the same years, the Italian Ministry for Health published the National Antimicrobial Resistance Plan. It was based on 5 aspects. These aspects are the same aspects focused by WHO in 2015. And the objects are the following: to improve awareness and education of health professionals, citizens, and stakeholders, to monitor the phenomenon of antibiotic resistance and the use of antibiotics, to improve infection prevention control, to optimize the use of antimicrobials in the field of human and animal health according to a One Health approach, to increase and support research and innovations. Correct approach to infection surgery. It should be based on infection prevention control, on antimicrobial stewardship and correct surgical technique. These are best practice. Infection prevention and control. Improving patient safety in hospitals worldwide requires a systematic approach to preventing healthcare associated infections and antimicrobial resistance. The two go together, and healthcare associated infections that occur while receiving healthcare, while the patients receive healthcare, are surgical site infections, catheter-acquired urinary infections, hospital-acquired pneumonia, and central venous catheter-related bloodstream infections. In the last years, 2 sets of guidelines were published. In November 2016, the global guidelines for the prevention of surgical site infection were published by World Health Organization, and in 2017, Centers for Disease Control and Prevention guidelines for the prevention of surgical site infection were published. But it is important, and first of all, we should stress the concept of clean our hands. There are generally 3 primary levels of influence related to behavior modification: intrapersonal factors, interpersonal factors, and institutional and organizational factors. What the Italian the surgical societies have focused these aspects. Intrapersonal factors. On an individual level, healthcare workers should have the necessary knowledge, skills, and abilities to implement effective infection control practice. Increasing the knowledge may influence their perceptions and motivate them to change behavior. Education and training represent an important component for accurate implementation of recommendations. Education include efforts to improve educational programs, and it is important to incorporate fundamental antimicrobial stewardship and infection prevention and control principles in under and postgraduate training at medical faculties to keep young doctors and other healthcare professionals with the required confidence, skill, and expertise. In 2019, ACOI, the Italian Surgical Society, organized 9 meetings around the country from north to south to discuss about the prevention of surgical site infection. And the meeting were based on the principle of the prevention of surgical site infection according to the global guidelines for the prevention of surgical site infection, and on the document published by Regione Emilia-Romagna and Maria Luisa Moro, that in 2017 published a very, very clear manual about the prevention of surgical site infections in the Italian language. Interpersonal factors. It is important to increase knowledge alone. Increasing knowledge alone may not be sufficient for effective infection control and may be insufficient to effect sustained change, especially in considering the multifactorial nature of the problem of healthcare-associated infections. It is important to introduce the concept of the champion in preventing and managing infections. Clinicians with knowledge and awareness toward surgical infection can integrate best clinical practice and drive the colleagues in changing behaviors. Identify a local opinion leader to serve as a champion may be important because the champion may integrate the best clinical practice and drive the colleagues in changing behaviors. working on a day-to-day basis and promoting a culture in which infection prevention control is of high importance. In Italy, we are working about the figure of the champion, of the surgical champion, with the ACOI, the hospital, the surgical society, the Italian Surgical Society. We are working about the figure of the champion. We are looking for champions about surgeons that who can spread the concept of best practice in prevention and management of the infections. We are organizing webinar meeting, and we are identifying the champions in every surgical department, in every hospital in the country. Really, we are working about the figure of a surgeon champion from 2-3 years. In 2018, the World Society of Emergency Surgery published this first paper about knowledge, awareness, and attitude towards infection prevention and management among surgeons, identifying the surgeon champion. This is a recent paper we have published into World Journal of Emergency Surgery about the figure of the champion preventing and managing surgical infection. We have translated the paper in Arabic, Chinese, French, German, Italian, Portuguese, Spanish, Russian, and Turkish. It is important that we have spread the Italian translation to all surgeons, around the country, about the mailing list of the ACOI, the Surgical Society of Hospital Surgeons. Then, institutional and organizational factors. Organizational obstacles may influence infection prevention and control implementation. Many different hospital disciplines are typically involved in infection prevention control, making collaboration, coordination, communication, teamwork, and efficient care logistics essentials. In Italy, last year, we have organized in my university a consensus conference with a multidisciplinary task force of experts, and we have published a document representing the executive summary of the final statement approved during the consensus conference. This is the paper. It is a proposal for a comprehensive approach to infection across the surgical, and in this consensus conference, in this paper, participated surgeons, participated infectious disease specialists, participated epidemiologists, hospital pharmacologists, hospital pharmacists, and nurses. It is very important to implement the multidisciplinary approach about interdominication. This is in this case, we have tried to implement multidisciplinary approach. The paper of the consensus conference concluded with this period. Leading international organizations such as WHO acknowledge that collaborative practice is essential for achieving a concerted approach to providing care. Prevention and management of infections across the surgical pathway should always focus on the collaboration between all healthcare professionals with shared knowledge and widespread diffusion of best practice. As acting director of the Global Alliance for Infection Surgery, I would like to conclude with our motto: enhance infection prevention and control, prescribe antibiotics when they are truly needed, use antibiotics appropriately, control the source of infection when it is needed. Together, we can impact millions of people. Thank you very much.
Thank you so much, Massimo. Thank you so much for the nice presentation. And now I will give the floor to Josep Badia from Spain.
Okay, thank you. Let's see if I'm able to share the screen.
Okay, yes.
It's okay on your side?
Yeah.
Okay, thank you.
Perfect.
Okay, then, good afternoon. It's for me a pleasure, a real pleasure to participate in this session. And I would like to start by thanking Health First Europe for the opportunity of sharing our results of several studies we have undertaken to demonstrate the gap that exists between evidence and clinical practice in SSI prevention in Spain. I'll spend, I'll spend just a minute to remind you that even though we have got many guidelines on SSI prevention developed by respected organizations, we all know that the main issue with guidelines is compliance. With this idea in mind, in the Spanish Observatory of Infection in Surgery, we decided to investigate how the recommendations of the main guidelines, in particular the most recent WHO guidelines, had been accepted in Spain. The questions were aimed at not only finding out the level of implementation of the measures, but also their awareness of evidence and their personal beliefs about them. The first survey was addressed to general surgeons, and we uncovered a few areas for improvement, which I'm going to show you. Starting by hair management, you can see the slide, we were not happy to notice that 60% of surgeons were still recommending routine removal of the hair, with only 5% not removing it from the surgical field. Even worse, we learned that in almost 30% of the cases, hair removal was being done with a razor instead of a clipper, which is the recommended method in all guidelines, as you perfectly know. Regarding skin antisepsis, we asked the surgeons which antiseptic solution was being applied for skin prep for healthy skin with no mucosal proximity. Then again, as you can see, we found that in 50% of the cases, non-alcoholic solutions were being used, which is a non-recommended method in all recent guidelines. When we ask about safety items, the answers were quite concerning. First, in most of our operating theaters, large bottles of antiseptic solutions are used, and we know large bottles can become contaminated. What is even more concerning is that despite the fact that a third of the responding surgeons have heard about problems related with alcohols in theaters, only 52% of them allow alcoholic solutions to air dry before applying surgical drapes. And you know this is a safety issue. We did this second survey directed only specifically to colorectal surgeons. In this case, we added some more questions related to their knowledge and personal beliefs about preventative measures for SSI. Let's see some of the results. In general, we found two patterns of response. First of all, in this slide, you can see a pattern of a good level of agreement with less than 25% of differences between the beliefs and the practice of the surgeons. For example, on the left side, they believe that an alcoholic solution must be used for skin prep, and they use in the same percentage. Also, with a good level of agreement, there are some methods that respondents believe have no evidence and that in fact they are not using, as you can see on the right side of the graphic. On the other hand, we found a different pattern which shows a high level of disagreement between beliefs and protocols. For example, surgeons believe there is no evidence for wound irrigation, but it's a widely used method as is shown in the slide. And the same happens with the changing of gloves or surgical instruments at the end of the operation or anastomosis. There is no evidence, but luckily I think most surgeons do this. The results about mechanical bowel prep and the use of oral antibiotic prophylaxis are somehow shocking. Despite the fact that many surgeons believe in the benefits of oral antibiotic prophylaxis, as you can see, few of them use it. On the contrary, few surgeons believe in the efficacy of bowel prep to prevent SSI, but many actually use it, mostly in rectal surgery, I must say. As you can see, some of these results are quite surprising. Finally, we recently published another survey. This time it was among surgical nurses and surgeons from 9 different specialties, from urology to heart surgery. Asking about the duration of antibiotic prophylaxis, we discovered that almost 19% of surgeons prolong the administration of antimicrobials for more than 24 hours. This is really concerning. Although we observe wide differences according to the specialty, as perhaps you can see below. The results on skin antisepsis were a bit better than in previous surveys, as alcoholic solutions were used in 65% of cases, still with important deviations according to the surgical specialty, as again you can try to see below. If we talk about wound edge protection, we found that the most common method is a double ring device. But we were really surprised to discover that 16% of surgeons do not protect wound edges, and in 30% of cases, they still use permeable devices. Now, regarding antiseptic sutures, we found that they are not commonly used at present, as less than 20% of surgeons use them either always or sometimes in their practice. However, again, this rate changes a little bit according to the specialty. Wound irrigation is for me a very interesting subject. In brief, we found that 80% of surgeons from different specialties irrigate wounds before closing the wound, closing the abdomen or the thorax, in most cases with saline. Well, this is in summary what we found in this, our first project of our observatory, when we were aiming to identify and raise awareness on the mismatch that exists between recommendations and the level of compliance in real practice. In our last survey, we asked surgeons how they think this translation of evidence into practice can be made. And for the most part, their responses were very, very remarkable. The most highly rated approaches were the least used strategies in their hospitals. The respondent surgeons put forward educational programs, feedback of results to surgeons, and the development of fast-track protocols and bundles for SSI prevention. But as you can see, few of these strategies were in place at their centers. In conclusion, it seems that there is an actual mismatch between evidence and practice in the prevention of postoperative infection. We can say that guidelines are of course necessary, but probably are not sufficient in themselves, as we detected several areas for improvement. Finally, we think that perhaps the human factor within a teamwork environment is essential to implement bottom-up prevention strategies that may come from scientific institutions and guidelines. This has been our first project, identifying the gap. Now we're trying to fill it, but this is another story. And that's all. I thank you very much for your attention.
Thank you so much. Thank you. Okay, thank you. Now I'd like to give the floor to the next speaker that this time will describe the situation in the UK, and with Professor Peter Sagar.
Thank you, Melina. Can you see my slides okay?
And now we cannot see your slide.
I've sent it across to you.
Okay. No, we cannot see the slide. It's the green icon. Okay.
Yeah.
Yes.
Can you see me now?
Yes, perfect. If you can make it bigger.
Is that
okay.
good?
Perfect.
Okay.
Thank you.
Well, first of all, thank you, Melina. Thank you, Health First Europe. And thank you for 3 very interesting talks. I've taken the title of this literally, and I think it'll fit in nicely with Dr. Beckstein's comment about Sisyphus pushing the stone up the hill, and also Dr. Badia's comment about human factors that seem to make a big difference into what we achieve. I'm going to take this back to basics in terms of what we do in the United Kingdom, and in particular highlight the NICE guideline that came out earlier this year, which is looking at prevention of surgical site infections. And this is basically the UK guidance from the National Institute of Clinical Excellence in order to reduce our similar problem with SSI. So going back very much to basics. First of all, the preoperative phase. Simple matters such as preoperative showering can be critical in reducing SSIs. And whilst the panel will be surprised, it's not surprising to be working clinical practice, how few patients come in with a lack of a basic human hygiene. I'd agree with the comment about hair removal. It's electric clippers, not razors. If Staph aureus is a concern, then it's critical to decolonize the nose with mupirocin and chlorhexidine body wash. That's an absolute standard. The clothing worn by theatre staff is also critical, as is avoiding going back and forward between theatre, between other theatres, cross-contaminating. The comment about mechanical bowel preparation is very interesting. I too am a colorectal surgeon, and it's interesting how things have changed over the last 20, 30 years with regard to the use of oral antibiotics and bowel prep. As a colorectal surgeon, you'll tend to bowel prep left-sided tumours simply because you want a clean bowel to anastomose. With regard to antibiotic prophylaxis, I'd highlight a number of studies that have gone on over the years, including from our institution, the John Gallagher unit, back in 1971, so 50 years ago, looking at randomized controlled trials for this very problem. It's critical that antibiotic prophylaxis are used in specific circumstances, and particularly when areas such as the GI tract are opened in order to minimize SSIs. With regard to the choice of antibiotics, it's also critical that you listen to your local formulary, speak with your microbiologists, and making sure that that first IV dose is given at the start of anesthesia with a fallback position. If you're going to do a long operation, you make sure that second dose is administered. With regard to the intraoperative phase, hand decontamination is critical, and it's interesting to see the older surgeons tending to use 2 or 3 minutes, whereas the younger surgeons will be very fastidious with the use of 5 minutes using a single-use brush, etc. With regard to drapes, we do use the iodine-impregnated drapes as appropriate when there's no iodine allergy present. Double gloving, again, this seems to be an age-related phenomenon. Older surgeons tend to single glove, younger surgeons tend to double glove. Antiseptic skin preparation, I take Dr. Badia's comments, but we've had recent problems in the UK with the use of alcohol-based solutions of chlorhexidine splashing into or dripping into eyes and causing significant ocular injuries with regard to damage to the mucous membranes. So in such cases where there is any risk to mucous membrane, particularly eyes as highlighted by a recent run of a few cases, we would then use the aqueous solutions. But it's critical to follow this sort of basic list of antiseptic skin preparations that are being used for specific reasons. Intraoperative phase. We do not use diathermy to incise the skin. That tends to cause more SSIs. It's critical to make sure you've got appropriate patient homeostasis, including the use of the bear hugger. Been a lot of debate over the years about the use of both wound irrigation and intracavity irrigation. We wouldn't use it routinely, but if there's been any contamination, for instance, a colorectal procedure, then we would use that liberally in order to make sure the site is left clean. Before wound closure, we would not use antiseptics, antibiotics, unless it's part of a randomized controlled trial. And with regard to closure methods, there doesn't seem to be any difference between the use of sutures versus staples, although a NICE guideline will recommend sutures after cesarean section to a significant number of superficial wound adhesions. Antibiotic impregnated sutures for skin tend to restrict it to pediatric cases. Wound dressings. Difference between North America and Europe seems to be wound dressings are removed promptly the first day after surgery in the North America, where certainly in the UK they seem to stay on for 1 or 2 weeks, which seems a bit long in my opinion. And we do need as surgeons to be aware of appropriate dressings to use when there is exudate present in the wound in order to speed up the healing of such wounds. In the post-operative phase, as I say, if you are going to leave the dressings on, it's critical that an aseptic, non-touch technique is used to change and remove the dressing. In our practice in the north of England, we tend to clean the wound with saline for 48 hours, shower safely after 48 hours, and leave the wound dressings off. Dressings to be avoided when you're having a wound healed by secondary intention would be Usol, which was phased out 10 or 15 years ago. Gauze or mercury-based solutions no longer used. And any trouble with wounds, it's important to promptly get the tissue viability nurse along for their opinion on further management. Debridement is used as and when necessary. Don't leave these wounds an inadvertent long time before debriding when there is breakdown of the wound. If there is evidence of a surgical site infection, then it's important to liaise with the microbiologist in your local drug formulary, making sure you've got an appropriate antibiotic to cover the causative organism whilst minimizing local resistance, which we mentioned several times this afternoon already. So discussing microbiology and using the various algorithms that most hospitals and most national guidelines will produce in order to achieve a prompt and successful outcome for that particular wound. If there is significant intra-abdominal infection, then again, standard use of antibiotics according to local formulary, or in the UK, these specific antibiotics for either sepsis or severe sepsis. And as a colorectal surgeon, I'll finish off with a few specific comments. It is very important to achieve source control if there is a post-operative infection to minimize the chance of the abdominal wound, for instance, becoming infected. Getting adequate drainage is very important, and having suitable interventional radiology in order to drain infection and therefore avoid going back into the abdomen or chest in order to establish control of that focus of infection. 2 or 3 final points. First of all, if you're bringing out a stoma, it's absolutely critical that it's brought out at the appropriate position, suitable for the patient and distant from the midline or other incision, so there's no contamination from the bowel effluent. And one final point with regard to COVID, we've moved very much in the UK since March of this year to the use of antibiotics in appendicitis. There's been data available for some time with regard to the positive benefit of using antibiotics in most, but not all, patients with appendicitis, and that has reduced our laparoscopic and open infective rates after appendicitis. Not that open appendicectomy occurs very often in the UK. And finally, the duration of treatment, we'd usually give antibiotics if there is an SSI for 4 days after you've got control of the sepsis, waiting for the neutrophil count to go back to normal. And again, if we are going to switch to oral, that's usually done with the advice of microbiology. In conclusion then, I'd echo the point of Dr. Beckstein and Dr. Badia with regard to there are no barriers to the various guidelines and protocols we've got. Most of the barriers come from resistance from the staff themselves. It's important as senior surgeons we show a good example in order to adhere to all those factors I've described this afternoon. And although we've got very clear and often very simple guidelines and protocols, practice is not always in keeping with those guidelines, and some of the old ways persist. With regard to the data in the UK, the Care Quality Commission, or the CQC, is very good at observing and reporting back, and each of the hospitals in the NHS gets regular visits from the CQC who report our SSIs and report on our practice. Thank you very much.
Thank you so much. I have one question for the speaker of this panel before we move to the coffee break. Since several of you mentioned about professional resistance to improve the guidelines, How do you think that concretely we could somehow to overcome this resistance? I don't know. It's about education, it's about training, a new incentive. What can we do? Also as a ask for like the policymaker to try to change the current situation.
I think you can have lots of guidelines, you can have lots of educational sessions and so on, but the ultimate fact is good behaviour in theatre and adhering to those guidelines. And it comes down to the senior member of the team making sure you follow all those guidelines, pre-operative, intraoperative and post-op. So critically showing a good example to all the rest of the staff.
If I may add and go along with that, I think the awareness of the importance of health-associated infections, including SSIs, should start at the basic formation of medical students. So this is really the first place to implement this. And then as Dr. Sagar has rightly, Mr. Sagar, sorry, has rightly pointed out, it is critical in the units, in your daily work, that the most senior member gives an example, is at the top of the latest evidence. There you have to, I think, really go for a bottom to top approach. So it has to start on the daily work floor and implement it from there, and use an interdisciplinary outlook with aligning with microbiology to look at your local resistance situation that you have, rather than have a policy that seems to be implemented from top down, from management or whatever. So I think the bottom-up approach is very important.
If I may, I think one of the most important things is surveillance, to evaluate our results and then to give feedback to providers. In our surveys, we discovered that 50% of Spanish surgeons in all specialties don't receive feedback of their infection rates. I think this is the first, the second step, to evaluate, then give feedback, and then to try to engage, as has been said, try to engage frontline personnel in the implementation of those guidelines they received from above, from different organizations.
If I may ask, Dr. Badia, now you were proposing a individual infection control regarding SSIs for each practicing surgeon. Did I understand that correctly? And if it is so, how do you allow for risk, how do you say, to take into account the risky population? Now, if I look at what Mr. Sagar is probably dealing with, are, for example, a patient with a perforated sigmoid diverticulitis, with feculent peritonitis in all four quadrants. Now, clearly, this patient would have a higher risk, independent of the surgeon and the practices that you use, compared to one who's got a simple, uncomplicated appendicitis that may be treated by laparoscopic appendectomy if he did not receive antibiotic treatment.
Yeah, of course, those results must be adjusted to the case mix of each hospital. I was referring not to the individual rate of the surgeon, but maybe better to the team rate, the rate of infection of each team. For example, the colorectal surgery team of each hospital.
Melina, tomorrow we start the World Week awareness, antibiotic awareness week. We should increase awareness of clinicians, of surgeons in the prevention and management. In Italy, we have very few data, and we don't know really how we prevent surgical site infections. But I know that in Italy, but I think all around the world, we should implement the awareness of the prevention, of infection prevention control in all clinicians.
Okay, thank you so much, everyone. And now, if you agree, I will go for a wellness break because I think that all of us, we need to move for 15 minutes and see you here again in 15 minutes. You can leave the call open. I will put everyone on mute. No worries. Thank you.
Yeah.
Thank you.
Thank you.
Hello. Hello, everyone. Okay, I see that everyone is still there, then this is good. I was worried it was everyone after the break. Okay, then thank you so much. And I think we can open the second part of our meeting. And I'm pleased to give the floor to Professor Kemal Raza. Please.
Thank you. I think I can share the screen.
Yes. It's just the green icon.
Yeah.
Okay, perfect.
Perfect. So thank you, Melina, and thank you, Health First Europe, for this opportunity. And I've been thinking at the coffee break that I'm getting old each year because I know many of the bugs, more than 20 years maybe. For example, Badia from SAC, more than 15 years at least. And we have a couple of friends from Massimo, Claire, Benedetta, more than 10 years, I think. So thank you for the opportunity, not only presenting our data or our view about the surgical site infection prevention, but gathering all us. This is a great initiative. Thank you all. So today, first of all, as Massimo just reminded us, there's a World Antimicrobial Awareness Week starting tomorrow, and I think we must spread, we must get viral about this event, this very prominent event, and I want to thank Benedetta and her team about this awareness. I think this is important for not only healthcare, but all the humanity. So today we'll explore answer of 3 questions at the agenda. How should we coordinate and standard guidelines in Europe, and how to ensure the highest levels of guideline implementation? I think Benedetta will explore it much more than me, and which actions should be adopted at the policy level. So we have at least 3 or 4 major prevention guidelines for the surgical site infection prevention. The first appeared at 2016, the American College of Surgeons and SAS. The second one, which Benedetta and her team, and I'm very delighted to participate in part of it, the WHO guideline, which is published at 2016 and revised at 2 years later. And the other one at 17, CDC prevention guideline. And we have some discrepancies about the guidelines, about those 3 guidelines, and we have some very strong agreement on some issues like parenteral antimicrobial prophylaxis, alcohol-based skin preparation, perioperative glycemic control, temperature regulation, and maintenance of normal tissue oxygenation. And but in the other parts, we have no unanimous agreement of it. So I really like the Kemal Itani's this paper at YAMA. We must look beyond these current guidelines, and we have some discrepancies about those issues. And each year after 2017, for each element, we have been growing new evidence which can change this current guidelines. And so it advanced in a global scale, and I can just name it. We are in a post-guideline era. And again, I want to congratulate Benedetta and our team about the last paper on PGA about the effectiveness of oxygen, and that this is a change, rule-changing issues, and we mustn't neglect those new evidences. So we must have guidelines, but we must look beyond it. And also we have very new, challenging developments which can change surgical dogma and long-standing practices. And the one which Heather Evans from America just provocatively just introduced to the literature, the mobile phone applications. And I'm really strong believer of this. And in a couple of years, I think we'll survey the surgical site infections by using our cellular phones and by using our high-tech equipments. And this will invent earlier detection of SSIs and decrease, especially in the high-risk patients. Early intervention will have a great impact on the outcomes. So I think this mHealth issues will be more visible in the coming years. So our challenge, I mean, one of the major topic of this today's topic is how we can translate guidelines to action from paper to the bedside. So we have 4 guidelines which are very solid, though they have discrepancies. We have some challenge for implementing it. So I know I really love this quote, the very first sentence of the Anna Karenina. All happy families are alike, but each unhappy family is unhappy in its own way. I mean, each institute or each country, each geography has its own challenge. Some have challenges in the surgical ecosystem. Mainly, we can consider low or middle income countries about those challenges in their ecosystem. Some have problems in guideline compliance, and Badia underlined this fact during his talk. We must have a feedback for each surgeon or each MD for their guideline compliance. I mean, they must know the place of their scores or their compliance. And we have great power struggles, especially in my geography in Middle East. We have some egos, some power wars in the hospital, in the country. So this definitely negatively affects all the system. Some we encounter with some situational personality disorders. I may be the example of this. So each unhappy family with high surgical site infections have some challenge, and we must have a very complex, a cooperative, complexive point of view to overcome those issues. So this is our in a way Bible or Quran. How do you call it? I can consider it as a holy manual, which I'm also delighted to be a very small part of it. The Benedetta and team just published it approximately 2 years ago, and we just underlined the fact of we now know the subtitles about how we can proceed to success. So we must all be aware of those facts, and while dealing with a problem, surgical site infection problem, for a geography or for a country or for a center, we must regard those issues, and we must check all those titles one by one to overcome those issues. So the main, I also love André Picard, and what really matters most in healthcare is the human connection. I really love that quote too. So we must have a human connection for the implementation challenge, for the guideline compliance challenge. So if we can touch those peoples, if we can describe it, the importance of it, if we can use those tools for the implementation, I think we can have a success, that's for sure. So today I want to briefly concentrate on the importance of the societies in Europe. I want to give credit to my society that I'm really proud to be part of it, the Surgical Infection Society Europe, and also the World Surgical Infection Society, which is the umbrella society of all surgical infection societies globally. So those societies, SIC and WSIS, must take a responsibility for quality improvement process in Europe and maybe beyond. And we must lead and coordinate efforts for guideline compliance and implementation. And we must collaborate with the national societies like the great, brilliant Spanish society. I know they've been doing a great job, and also Italian society. I want to give credit to Massimo and his team also. So it'll increase the compliance, and it'll ease the implementation challenge, I think. So we can even adapt the surgical infection prevention guideline in a national level. I mean, we can say that those are the guidelines those are the new data after the guidelines published in the last 3 or 4 years. And this is your country situation, this is your challenge. And while considering all those components, we can create national guidelines by the help of or by the moderation of the European societies like SASC. And with SASCs and national SASC endorsements and collaborations, institutions can work on their implementation challenge, and definitely we can improve the processes. And we can even develop European-based bundles, which is definitely must be different, or it is different from the bundles of the North America, which must be different for the valid bundles for the low or middle income countries. So creating European bundles and other implementation resources, I think we will have a positive impact. And even we can build a European registry of involved institutions. I think this will be a great opportunity. And we should also team up with WHO. They're creating a great content, and they have been two or couple of steps forward of us. So we can team up with them, and like the examples achieved at the low middle income countries, I think at the policy level, we can have those achievements or those processings in Europe also. And we must also work with different initiatives like Health First Europe. I really appreciate their, for the last couple of years, you have been doing great things, I know, and we must promote those initiatives, and we must give a chair at the table for the prevention. And I want to thank you all for this opportunity, and if any questions, I'll be delighted to answer. Thank you, Melina.
Thank you so much, and I'm sure that there will be more questions coming. In the meantime, I'd like to give the floor to Benedetta Legranzi from the WHO. Benedetta, do you prefer sharing the PowerPoint? Okay, perfect.
Hello, can you see my slides?
Yes, but I think you need to go to slideshow. Okay.
Okay.
And make it bigger, like.
Okay.
Perfect. Thank you.
Okay, that's great. Good afternoon, everyone, and really many thanks to Health First Europe, and also to all of you who presented before me. I feel I don't have much more to say, to be honest, because I think when it's really frontline people and researchers and scientists talking about the key principles and also basically showing uptake of international and national guidelines and telling us about real life implementation, this is what we need. I don't think we need much more from our side. So thanks all, Kemal first, but all the others also in the previous session. So I think these questions that Kemal has already shown direct us towards the issue that we are discussing during this part of the conference, which is the focus on implementation. Basically, yes, we need guidelines, we need policies, but it's all about implementation at the end of the day. And in fact, let me divert for a second from SSI to more general IPC, infection prevention and control aspects, by showing you this slide coming from a survey we undertook 1.5 years ago, or almost 2 years ago now, in 88 countries worldwide. By looking at the uptake and implementation of our general recommendations for infection prevention and control programs. So you can see that 67% of countries were reporting to have IPC guidelines. But when asked in semi-structured interviews whether they had implementation plans and strategies for those specific guidelines, only 36% were able to say that they had specific strategies. And the other element is that only 22% of these countries had a system in place to monitor actual compliance with the recommendations, whatever the guidelines were. These were specific IPC guidelines or general IPC guidelines, no matter. The problem is implementation. And in fact, again, taking a step back, I would like to remind you that we identified what are the core components of effective IPC programs and published these guidelines, and also what are the minimum requirements. And among these, we say that countries need to have evidence-based guidelines, but also with those guidelines, there should be educational and training pathways to teach about the guidelines principles. And also there should be a system for monitoring adherence or compliance to those recommendations. This is part of one package of strong recommendations about guidelines. So if we need to think about Europe and policies, let's think whether there are SSI prevention guidelines, but also whether there are systems for educating and monitoring. The second point is really about the core recommendation, in my opinion, of our core components, that is having strategies for implementation, which means multimodal strategies. And again, we have strong recommendations for having these strategies in the national plans and then really implemented at the facility level. In fact, another element of the core components is surveillance. And in fact, I'm showing you this report, which was mentioned also earlier by Dominique Monet and others. ECDC does a great job with the TESI and other type of networks to collect data. You can see that many countries in Europe collect data on SSI and provide data to ECDC. But then I think the activity that we need to enforce also through ECDC and WHO and other societies is really in Europe to be able to work together to translate those data in action at the point of care. Understand what does surveillance tell us in terms of SSI incidents, but also risk factors and other indicators that are monitored by ECDC and others regarding SSI prevention measures. We need to transform data into action. So then, in fact, this leads us to our framework for implementation that can be applied to any program. In this case, we are talking about SSI, but it can be applied to any IPC program. And it consists of a cycle in which in step one, we understand what the problem is and what is the problem we really want to tackle. In this case, is safe surgery affected by SSI. Then we measure the problem with surveillance, as I said. Then we develop a plan for implementation, and we will talk about this in a minute. We evaluate the impact, and then we understand what are next steps for sustaining this program for SSI reduction, for instance. And this means that, for instance, in a facility, it will be very difficult to implement all 29 recommendations at once for SSI prevention. And this is why you need a cycle. You need a cycle in which every year you may want to reinforce 3 or 4 or more or less SSI prevention measures in your facility. So the second point is really the multimodal implementation strategy. So here you have it as it is represented in the manual that Kemal very kindly showed us. And people may remember that this strategy was implemented, adopted, and adapted then from the hand hygiene implementation strategy. So what does it mean? It means that if you want to improve an end outcome, such as SSI or associated outcomes, you need to tackle this problem in different ways in your facility. It's not enough to either doing training or procuring chlorhexidine-based, alcohol-based solutions for skin disinfection or antiseptic searchers. It's not sufficient to tackle only one aspect. You have to have a system change to understand what is the equipment or the infrastructure that you need to have in place. You need to be able to educate people on a specific measure. You need to provide them with data about their practices and therefore feedback. And then you need to continue to remind them. The checklist, the safe surgery checklist, is one possible reminder, but there are many others. And especially you need to embed and really permeate all of this in a cultural change, in an institutional safety climate which involves everyone. And we will come back to this later on. So this is a multimodal strategy that can be applied to each one of the SSI prevention recommendations, like it is explained in the manual. The second point that is absolutely necessary is that this is a joint venture that absolutely requires a multidisciplinary team. There is no way that SSI prevention is either the area for the IPC team or the IPC focal points or the surgeons or the anesthetists. It's a joint venture, and none of these categories can succeed in doing this venture, in implementing these programs. And this is why there are different roles for different people within the multimodal strategy. So a pharmacist will be essential to the system change in procuring the right antibiotics or procuring the right product for skin disinfection. The anesthetist will be absolutely necessary for implementing, for instance, the hyperoxygenation recommendation. The surgeons and the surgical team, of course, they are essential to almost all the recommendations. And the next concept is really to facilitate this very complex implementation of so many recommendations by really trying to address the right professionals according to the period during the surgical patient journey. So whether it's preoperative, intraoperative, or postoperative, there are different people who have a role and different recommendations that can be implemented. And this includes also, in some cases, the involvement of patients and families. So then there are different ways of showing this surgical patient journey, and I think that the local creativity also would be very nice to be taken up and used to adapt this kind of visuals. Now, the last point I really want to go back to is the institutional safety climate. So here I'm showing you data about the implementation of the hand hygiene program. So it's a different story, but as you can see, this is a survey conducted last year by WHO in more than 4,000 facilities worldwide. And we were looking at the level of implementation of the different 5 elements of the multimodal strategy. In this case, it was related to hand hygiene, but the story is the same. You can see that the scoring related to an institutional safety climate was the lowest. And this is not the only survey that demonstrated that this is the most difficult element to be implemented, but it's also the most important in my opinion. So in fact, this was also demonstrated by another piece of work. A couple of years ago, we did a systematic review looking at the most successful studies on SSI reduction in the literature and looked at different strategic approaches. The strategic approach of having at the facility level an engagement strategy of different players was very common in these studies, in 60%, 63% of studies. That involved involving and engaging the leadership and the senior executives, but also really engaging frontline staff, each one of them, understanding the implications of SSI and their role in prevention. The other element that was clearly demonstrated in all these studies was having multidisciplinary teams and the importance of local champions taking ownership of these projects and these behaviors of a safety culture in the surgical care environment, like many of you have already reminded us. So this is indeed what we recommend in our institutional safety, climate and culture change that we have in our documents. We call it Live It, meaning live this program, live it in your daily life. And I like saying also love it, not only live it, love it. And it means doing different actions, as I mentioned before, involving the leadership, engaging champions and role models, doing morbidity and mortality meetings focused on SSI and their consequences, and having advocacy messages from leaders. My last slide is about the fact that we were able to prove in a different way that these elements I've just mentioned were the key elements and facilitators that led to successful implementation of our strategy in some African hospitals, which we published some years ago, as you may remember, in the Lancet Infectious Diseases. This paper that is cited here is a qualitative paper that was the sister study we did with the quantitative paper that I mentioned we published in the Lancet Infectious Diseases. So this qualitative study demonstrated that the facilitators of the success were actually using a multimodal strategy, having a dedicated multidisciplinary team and a stepwise action plan, empowering teams, catalyzing the collective and individual ownership of the project and the program in the operating theater, and using data, local data, during implementation for creating local awareness and motivation. So these are the key messages that I wanted to convey to you. I also wanted to remind you that we have many other tools that can be accessible. And finally, I would like to invite you to participate in the World Antimicrobial Awareness Week. Tomorrow is the day that ECDC celebrates, and following that day, we also have a week. And tomorrow we will talk about IPC expertise that needs to be put at the service of other professionals, such as the surgical team, and we will talk about this in a webinar. With this, I would like to thank you very much. Thanks a lot.
Thank you so much, Benedetta. Really interesting presentation. Now, in order to implement a multimodal strategy, as you were mentioning, I think it's really important to adopt a preventive approach in healthcare. And in this regard, I'd like to give the floor to Dr. Paul Garsus from the European Union of Private Hospitals. Paul, okay, yes. Okay, yes. Do you want me to share the PowerPoint?
Yeah, you can start, Medina. Thank you for your support.
Okay, yes. Give me 1 second. Paul, yeah.
Yeah, that's me.
Okay.
First of all, thank you to Roberto Bertolini and Health First Europe's team to invite me to present you what is UHP and its engagement concerning quality of care, and more specifically concerning the healthcare associated infections. Possible, Melina, to have support?
Yes. Can you see it? Okay, I will make it bigger. Voila. Okay, view. Voila. Okay, he's here.
Perfect. I want just to follow the two former speakers, because that's exactly my message. I have to translate guidelines to action and to implement the best practices. And I am at action level. I have to win this challenge, to support the teams to be engaged in quality of care. Thank you to WHO to present some very, very interesting guidelines helping us to diffuse best practices. UHP is a federation of private hospitals at European level, representing about 20% of beds, but some members are more concerned by surgery. For example, in my country, in France, private sector represents more than 50% of all surgical procedures. So we are clearly engaged in quality of care and to reduce adverse events. May I just show you very shortly some data concerning healthcare associated infection. You know that, but it represents about 5% of all complications observed after a surgical treatment. But more important, it concerns severe infection, sometimes with multi-resistance bacteria. We have to be very careful about this very dangerous complication. The next one, please, Melina. And what we need first are data. And when you show this, this slide, you can see that incredible differences among countries. It's not so clear to understand. We need transparency to have all the data, all the report, useful to analyze how critical is the situation. May I say that adverse events represent, according to international literature, from 4 to 17% of all procedures. And most of them are preventable. We have to work all together in this prevention because it's a more cost-effective process to obtain a good result for our patients. And it represents a big amount of money if we can reduce waste and complication, adverse events after surgery. We can improve globally the success of all our healthcare systems. And what is the major goal I have to share today with you is a return on invest capital. But the invest capital today is not financial, it's human capital, because we have to protect our patients during surgery. Next one, please. I have to say first, we have to be simple. We have to be simple to prove that we are engaged in this process, and we have to be able to convince all the teams they have to respect the guidelines. And I suggest a very short sentence: collect and correct. We have to collect all the adverse events occurring during the stay. It's important for me to say that because it's not so easy to obtain all the report. And then, after analyze, we have to correct altogether what are the bad situations we observe. Naturally, we are supporting all of the best guidelines, WHO. But we have to say, be simple first. Hygiene is a first step. Just an example, as a platform, we invited a discussion concerning hand drying in hospital. It's a global process. It's not only one strategy and one step. It's clearly a global perspective concerning that quality. It's at the beginning of the stay for the patient and not stop at the end of the stay. And what is the case success? To implement them. I am an actor in the field, and I have to be the partner of the guidelines and give the best analysis I can read in international literature, but to be sure that all the teams are concerned by the problem. The collaborative process is a key success. We have to obtain to reach this goal, not only to declare it, but to prove it in the field, in every day. And what do we need? We need incentives, because it's important to have information, to know what could be a severe adverse event, but to correct them, we have to prove that it's a positive attitude we have to develop among our teams. We all, as the actors, we need nurses, medical doctors, and caregivers. One major aspect I have to say today, and I was very interested by the presentation at the beginning of the afternoon by our German colleagues, but we say that now we see a shift concerning the surgical procedures, and we observe more and more daycare units developing more and more procedures. And at this step, infections after surgical procedures can occur not during the stay in hospital, but be diagnosed after the stay. We need absolutely to collect all the data to be sure that the global system is good or not. And what we need is information. And it's very, very useful for me to have international data. And I remember I was engaged as stakeholder first in the joint action, patient and safety and quality, and moreover concerning the MIM project. MIM was Minimal Information Model for patient safety incident reporting and learning systems. That was exactly what we need to share information with experts, but to diffuse this information and this analysis in the field of each day working actors in hospitals. For me, Europe is really a chance to develop a positive strategy concerning the reducing a surgical site infection. Please further, maybe. Yes, just one example coming from our colleagues in Germany, the group Sana Clinic, Dr. Heidemarie Aske-Seeberg. And two major points. What is a quality information system? That is absolutely necessary to obtain data. And the other point, very useful in this field, is hygiene. All the data concerning infections, bacteria, and so on are useful to determine analysis and strategy. Go further, please, Melina. Again, and all must be collected in one catalog to say that in a global process, infections are very important, but not only the one point we have to analyze. And go further. And what we propose so is a dashboard, very useful to prove to the teams where we are. Specialty by specialty, groups by group, a specific hospital or not. You can have so a dashboard useful to implement the best guidelines we need and to see exactly where we are. This year, the next one or the first one before, because it's not always sure that was the best. You need always, every day, to work with your teams to improve the quality of care. That's the Sisyphus project, which was already presented during this session. Go further, please. And for conclude, may I say, as medical doctor, was what I teach at the very beginning of my career, primum non nocere. It's Latin to say, don't harm your patient first. That's very crucial for me. That's a global strategy, and we need to respect this principle. We need European data. We need a positive international benchmark. And at this moment, I would have to say I am medical expert in legal cases. And what I have to say, I am not the substitute of the patient voice, but we are talking here of infections and its patient harm. And what is so difficult in front of patients after a stay, after a surgical procedures, and this patient is infected. It's so difficult for them. It's painful, and it's a handicap, and they can perhaps no more walk or no more go further to work. So my initiative now is to say, yes, we need recommendation and guidelines, but I have to improve them, to adapt them to my everyday work, and to improve the quality of care in my own facility. And therefore, I need that all professionals must be informed of this situation and to use a recommendation and then to develop a positive strategy. And what is a win-win process? Only one word is prevention. Prevention is a training for the young generation to be concerned by this problem and then to improve and to respect the guidelines we need to implement in our facilities. So thank you for invitation. We try to really to do the best we can according to your guidelines and recommendations and to apply them for the full success of surgical procedures useful for our patients. Thank you to all.
Thank you so much, Paul. Thanks for your presentation. Now I will move a bit to the patient perspective. As we have been mentioning patients so many times during the conversation in patient arm, I'd like to give the floor to Paola Kugger from EUPATI, who will focus her presentation on institutionalizing a safety climate and culture. Please, Paola, the floor is yours.
Thank you, Melina. Thanks, everybody. And I see if I'm successful with the screen sharing. If not,
yes.
I will ask you.
Okay.
Because I don't see it.
Just give me 1 second.
No, I don't think I can manage.
There. No, there is Paul. Okay, let's close this one. Okay. Can you see it? Can you see the present? No.
No, not yet.
No, okay, just one
It's a bit
second.
tricky
Is this
with
one?
the system.
Okay, yeah.
Not that
okay.
easy.
Now
Okay,
you should be able
thanks.
to see it. I will make it bigger. Voila.
Thank you very much. So let me take this time to introduce myself. I'm a patient expert and a member of EUPATI. EUPATI is a European project that aims to train patients in the R&D of medicine. And it's also a foundation now, actually. And let me thank Health First Europe for having involved EUPATI to comment on their surgical site infection report and for asking me to be here today. Indeed, I think that patients have an important role to play in promoting a safety culture in Europe. So next slide, please. So why is that? Well, patients have evolved considerably in recent years, thanks to improved access to information and education. They are no longer just the end users in healthcare, but also active participants. And as such, they can play an important role in promoting a safety culture in European healthcare settings. To reach the same, patient education is key for 2 reasons. It promotes correct behavior and fosters collaboration between patients and HCPs, the advantage of which has already been highlighted in chronic care, where the positive alliance between patient and HCP leads to better health outcomes and increased patient satisfaction. The same concept can be applied to develop a safety culture. Educated patients understand why they have to follow certain rules and collaborate with HCPs in helping to detect potential problems for the benefit of all. Next slide, please.
Well, why? Okay, yes.
Excellent, thanks. So what are the key factors for patient involvement? Well, patients can play different roles. They can be potential transmitters of infections. They can be active or passive supporters of IPC, or they can be full partners through education and active involvement. Having patients as a full partner is becoming an important opportunity that cannot be overlooked, especially in a historic phase in which healthcare resources are limited. Indeed, several researchers stress the need to increase patient involvement in IPC implementation in healthcare settings and when developing also new guidelines and initiatives. To achieve the same, it becomes important to understand which are the key factors and the potential barriers for patient involvement in IPC. Next slide, please. Well, McGuckin and Governick argue that one cannot participate, be involved, or be engaged without the components of empowerment, including knowledge, skills, and an accepting environment. Strategies for involving patients in IPC can vary in terms of topic areas covered and levels of patient participation, from relatively passive strategies to active participation in IPC. Passive strategies such as written information and audiovisual teaching are described as potential tools to minimize risk of infection and promote patient engagement with IPC. Active strategies promote patient involvement beyond the development of patients' knowledge and skills for IPC, taking into account the patient's beliefs and experience. Next slide, please. But what are the barriers to active patient involvement in IPC? Well, there are two main barriers: relationship power imbalance and the lack of an organizational culture of shared responsibility. Tartari et al. State that our findings endorse the need for patient involvement in IPC and provide insights into a fundamental change to IPC as a common responsibility for both patients and ICPs. This change should be supported by a clear understanding of patient roles, potential levels of patient involvement in IPC, and strategies to overcome barriers in the professional-patient relationship. So what are the two key messages I want to give you today? Well, that providing patients with knowledge of IPC is a great opportunity to ensure their active role, advocacy, and responsibility. However, there is also a need to create an accepting environment for patient involvement in IPC and to put patients in a responsible and leading role as experts in their own care and IPC, rather than being passive participants and observers of HCP's behaviors. Thank you very much.
Sorry, I'm on mute. Okay, thank you so much, Paola. Now, basically, at the beginning of the afternoon, several times I recall that we mentioned the key role of education, training, and the educational system to prevent surgical site infection. Then I'd like to give the floor to Professor Pascal Astagnou.
Okay, thank you very much, Melina, and thank you for Health First Europe. I am trying to share my slides.
Okay.
Okay. That's it, I guess. Right, do you see it?
Yeah, it's perfect.
Okay, do you see? Okay, thanks. So at this time and at this step of the session, I am not sure I have something to add to what it has been discussed and presented before me, because everything has been told. So I'm trying to maybe stress some point, but probably not very new thing, because okay, I am a medical doctor, infectious disease and infection control specialist, working in Paris, and also teaching hygiene, infection control, and also public health in my university. And I am also the leader of the National Program for Surgical Site Infection Prevention at the national level, working with the National Public Health Agency. So at this time, I just want to make a short presentation and maybe trying to not repeat too much what it has been told and presented before me. First, just to stress some basic statements that everybody knows, but just for the one or two is very important to me. The first is that we know that surgical site infection are a priority in many countries. We know that surgical staff knows that it is a very important thing now, but in fact, nobody knows really what is the significant impacts on healthcare costs and patient outcomes. Many studies have evaluated that, and I just want to remind you that when it is a significant impact on healthcare costs and patient outcome, it is even more when the surgical site infection are due to multi-drug resistant organisms. And so I just mentioned one study, but I think there is others, just to remind you this point. The second point is that it has been stated that surgical site infection incidents, especially when you can evaluate the trends during the years, the secular trends of these incidents in many surgical wards. And if this trend is getting down, it could be a good indicator of what it is doing about cares or about quality of cares. But you need for this an easy-to-use surveillance system and a reliable measurement of the surgical site infection, which is not always an evidence. And I would say that based on the recent studies published by one of my French colleagues, Gabriel Birgan, in PLOS ONE, so in recent years, he demonstrated, based on the European participation, that SSI diagnosis, even if it is based on standardized criteria that everybody knows, the reproducibility of the definition of surgical site infection is now questioned. And so it demonstrated that there is a large variability of agreement among surgeons, first, but also according to specialty and also according to countries. So the problem is that we know that there is guidelines, we know that there is definitions, but in fact, in the field, it is not so evident that we can standardize, in fact, the measurement and also maybe the prevention. But I don't want to insist too much on this point because we have not too much time. So I want to skip more rapidly and focus to what it is my speech is for. So the special issue probably is that it has been already suggested in the previous presentation, is that we have many guidelines for prevention. We know what we have to do. There is, as it has been pointed out previously in this session, we know what the key points are consensual and what the key points are not. And WHO, CDC, ECDC, and all the national guidelines have the same, the same basis in terms of knowledge. The problem is that the transition to the actor in the field and what are effectively the knowledge in the field. So I don't want to stress that because it has been presented, but just for my experience in France, as we know, we have a national prevention program for surgical site infection in France for many years. And as you can see, if we look at the trends of surgical site infection incidence for the last decades, it's a decrease for about 50% in terms of incidence rate. So it's an encouraging result. But when we look more precisely for the last years, we are not sure that it is really accepted by everybody, because when we precisely look at some certain procedures, for instance, in gynecology or in orthopedic surgery, we could have a doubt of maybe there is some SSI surging. So why it is the case? As we know that for maybe more than 20 years, we have the right guidelines, and we can assume that most of surgical staff know it. Just look at for just some precise point, parenteral antibiotic prophylaxis. As it has been already said, it is a non-question problem, in fact. But when we look at the practice in the field, we can see that there is a problem, because in very frequent, it's relatively frequent that the PAP is delivered when it is not recommended, and it is also sometimes the case where it is recommended and it's not done. And so this is a problem of comprehension, of understanding, in fact, of what it has to be done, especially in some particular specialty. But I think it's the case in different specialties. It's not only one procedure or one kind of surgical wards. The other things is the delay of administration of the PAP. And as you can see, I'm sorry because I don't see my screen. Sorry, because I have the picture of mine just in front of my screen. Sorry. When you look at the administration delay, you can see the same thing. Is that for most of the case, it is the usual administration delay which is recommended. It's between from the prior to incision, the hour prior to incision. But when you look, if you accept the WHO guidelines, it could be 2 hours. But after that, you have not to make. Otherwise, it is recommended for, because the surgical operation is longer than it has been expected. You have not to deliver again PAP after incision. So this is one of the examples. The other example is about skin preparation. And as you can see, even if most of the case, the conformity rate for skin preparation, including all the criteria, is respected, is appropriate, except maybe in gyneco in this study, but okay. The problem is the contraindication. For instance, sometimes it's used with alcohol-based products, and we know that it's contraindicated on mucosa, for instance. But we can observe that it is made in a relatively frequent cases. And for shaving, it's maybe less frequent, but it would be, in fact, it should be around 0. So it's not 0, as you can see. Okay, so now look at what we can try to imagine when a patient is operated. For instance, I just take a study published recently for colorectal surgery, and we presented a bundle, as it has been suggested in the previous presentation. So a multi-approach, a multimodal approach for prevention. And you can see the different steps of an operation and what are the role exact of a healthcare professional in this case. So you can see that the nurse, they act at different steps and in different manners. So it's quite difficult to standardize exactly what they have to do. But we can point out especially some specific action. For instance, nurse have a responsibility in the preparation of the patient, but also his education in the preoperative period. The chief nurse had an important role in limited the traffic of the staffs in the operating room, which is an indicator of the quality in general. Anesthesiologists have also an important role in the preoperative period, especially for antibiotic administration. The surgeon, of course, have an important role during the operation, of course, but also after to survey the dressing with the nurse, but also to survey the potential occurrence of surgical site infection in the patient. And the nurse have also, of course, an important role in this post-operative period, as well as the anesthesiologist. So I'm sorry for this, because it's not exactly probably what you can live in the field. Maybe it could be different from one word to another, but I think it's a sort of general term that we can trust in. And so I try to, from this, make a sort of recap of what each healthcare professional category have to do, and what competencies they have to have, and what could be the training targets for them, and maybe at what education level. For the nurses, of course, pre-op skin, checklist, audit of practices are competencies that they have to get. for this, they have to be trained for disinfection protocol to know what kind of products, but also to know the procedure of disinfecting. Of course, to know the rules of hair removal, if hair removal is practiced, which is not the case in every world, as you know. To know the importance of clinical surveillance and clinical surveillance of the dressings, and to know how to make an audit on practice assessment and when they have to do it. And this kind of knowledge should be provided in both in the general tracks of the nurse courses, but also for specialized tracks, especially for nurses who have to work in the operating room, of course. In France, we have specific track. I don't know if it's the same in other countries, but we have specific track for operating nurse. So maybe it's not the same in the other countries. I don't know. For surgeon, of course, surgeon knows surgery, of course, but he have the specific role in SSI diagnosis. And as I just remind you at the beginning of my speech, it's not so easy to make a diagnosis of infection. And anyway, you have to also to make, if you have diagnosis, you have to know how to treat it, of course, but you have to know the criteria of surgical site infection. And for this, I think surgeons should have more, a course about clinical and microbiological aspects, especially concerning antimicrobial resistance. Maybe it's the case in some countries, it's not the case in others, and maybe depending on the university. In France, it's not standardized for that. He has to be aware also of the reporting system of HK-associated infection in his hospital, but also for, in general, adverse event reporting. And to understand what is a surveillance system, not only individual surveillance system for his patient, but generally the approach of the epidemiological surveillance. And for this, also, I think it could be very interesting to enhance the amount of hours of course during the specialist tracks of surgeons, and probably also in work or postgraduate diploma, if any. For anesthesiologists, it's the same, but maybe more focused on the antimicrobial aspect and antibiotic use and surveillance. And I would like to add something which could seem to me very important, which is the role of the infection control practitioner. Infection control nurse, and infection control practitioner, doctor or pharmacist in general, I think the need for having an ICP in the hospital to help the field actors to better implement the strategy seems to me very important. Of course, he has to be educated for that. First, in methodology of surveillance and reporting, and also, as it has been mentioned before, for how to feedback the data to the field team, and this is sometimes missing in some case, and for other things like communication and staff management. So it's a postgraduate education level for me, and it has to be implemented in maybe school of hygiene or medical school. Okay, so just to mention that in France we have a core competency guideline for the ICP, and just remind you that what is the role of an ICP, and this competency guidelines is in accordance with the Open Trials project, which has been done at the European level some years ago, where I participated a little. And so I think this is well known, but it is important. And to conclude, I would like to just stress some important key issue. How to improve the HCP in the education system on this topic of HI prevention. Whether it is at regional or local level, whether it is at the national one for a country, or maybe internationally or at the EU level. I don't know really what has to be done effectively, but I think it's important to think about. First, I think we have both to develop both in work, so it's probably close to what Professor Alegonzi told before, that it is, we have to implement an ongoing process of education of the staff, because it's impossible to acquire and to understand the several recommendations that we have in prevention of surgical site infection. So maybe it's an ongoing process, and an in-work education is very important. But at first, the academic education program has to be enhanced in many universities. In my country, I think it's not sufficient for probably at the very beginning level of the medical student or nursing school, it's not enough. And so we have to enhance that, and maybe all during the courses of the medical and non-medical healthcare staff. Secondly, we have to enhance the awareness and the feedback of IC, maybe using the new information technology. First, I am not a specialist of that, but just to mention that we have now virtual reality headphones, we have serious games, we have what I translate in French, it's a bloc des erreurs, but in English it could be operating room errors. And maybe also the simulation-based learning, which is very important at the very beginning, especially in the specialist tract. And so to conclude, I think we have to promote a global approach for patient safety and patient empowerment, and using the prevention of healthcare-associated infection as a trigger, in fact, for enhancing the patient safety culture. Thank you very much for your attention.
Thank you so much for this really comprehensive presentation, extremely interesting. I think that we will use again the slide with the different path, the different level for nurses, doctors, and so on. Now, since we mentioned so many times surveillance, I'd like to give the floor back to the ECDC, at this time to Dr. Tommy Karki, who will give an overview about active surveillance for surgical site infection and also monitoring of the implementation of prevention measures. Okay, yes. Perfect.
And thank you for the opportunity to present briefly the ECDC work on SSI prevention. I'll try to share my screen. I think it would work with this one. I wonder if I can put it to the...
Yeah, okay.
No, it's probably in the presentation mode and you should see that. So
okay, perfect.
Yeah. So I'm Tommy Karki from ECDC, an expert in the surveillance of healthcare-associated infections, working with Dominique Monet, who gave a short opening speech. And I'll briefly present the structural process indicator data that we are using collecting for surgical site infection prevention in our healthcare-associated infection network SSI protocol, briefly the pilot survey results, and then a few words on the continuous surveillance that we have planned and initiated. So as an introduction, in 2013 already, the Commission already requested that ECDC would collect data on structural and process indicators for all healthcare-associated infections. This was originally based on the ECDC Point Prevalence Survey 2011 and 2012, which then sparked this request. And on point prevalence surveys, we then repeated the health of structural and process indicator data in 2016 and 17 point prevalence survey. And we have planned of having these point prevalence surveys done every 5 years. But then in 2014 and 2016, ECDC then started discussions with our surveillance networks of the possibility of adding a set of internationally recommended and feasible structural and process indicators to our surveillance protocols, which are then implemented in the EU member states. And then in 2016-17, we organized a pilot survey of these indicators for surgical site infection prevention. So originally, how we selected these indicators for our protocol and for the pilot were done in discussions with our surveillance networks, and then in this pilot in 2016. And after these discussions that we had in several meetings, we selected a set of 6 evidence-based and feasible indicators for potentially to be included in our surveillance protocols. As we did this from a surveillance point of view, one of the important points with the networks that was continuously discussed was the feasibility of the collection of these data and the feasibility of doing it in a continuous surveillance instead of an ad hoc study kind of an approach. And our preference was towards numeric indicators such as compliance with the recommended practices, allowing, for example, improvement in time and more fine-grained comparisons between different countries and or facilities. The selected structural and process indicators were the following 6. So the administration of perioperative antibiotic prophylaxis within 60 minutes before incision, discontinuation of the prophylaxis within 24 hours after incision, and no hair removal, or if it's strictly necessary, then the use of clippers, alcohol-based skin antisepsis in the operating room, patient normothermia within an hour after the operation, and whether glucose monitoring was performed in the perioperative period. In the pilot survey that we did in 2016-17, we had 8 countries participating and 14 hospitals. And we allowed the hospitals to collect data for different surgical procedures that we have commonly in our European surveillance. And most commonly data was collected for cholecystectomies, cesarean section, and coronary artery bypass graft surgery. Overall compliance in all types of surgical procedures, like I said, from very varied type of surgical procedures, it varied from high for no hair removal to 64% for glucose monitoring performed in the perioperative period. When looking then more specifically in a certain procedure type, the median hospital compliance varied from 100% to alcohol-based skin antisepsis to only 1.7% in glucose monitoring. But of course, as we knew from our discussions and as was already discussed, some indicators are of course more relevant for different surgical procedures. So this is partially reflected, of course, in these results. And then we also asked in this pilot survey on how the countries had their national local guidelines. And 4 out of 8 countries in 2016 indicated that their national and local guidelines differed from the internationally recommended practices, which was an interesting minor finding. When looking for cholecystectomies, and it was actually only 3 hospitals and 81 operations, we saw, as said, a high compliance with no hair removal and alcohol antisepsis in the operating room. But for glucose monitoring, because of certain particularities, it was very low compliance. And then for the prophylaxis timing, the compliance was relatively high, but not perfect. And for the discontinuation, actually relatively low. And for normothermia, there was the largest variation on whether whether the practices were compliant in the hospital. Overall, in conclusion, in our pilot, the data collection for the structural process indicators, because we had this very limited set, it seemed feasible, although then in the end, even of these 14 hospitals, not all countries all the data for all these indicators, but still, it seemed that it would be possible in the surveillance. And in each of these selected indicators, the compliance varied, but also then between the types of surgical procedure, but also between hospitals and in the same surgical procedures. And when we see this, that hospital compliance within the same type of surgical procedure in our European surveillance or European hospitals would vary, it's a very clear indicator that there is room for improvement. Similarly, as for the national and local guidelines not being updated to the international recommendations in all cases. In overall, after the pilot, our recommendation was to further improve the prevention of surgical site infections, national and local guidelines should be updated. And then we recommended also that this selected set of the structural process indicators would be collected in the EU surveillance to facilitate the identification of outlier hospitals and to improve the prevention practices of both national and local level, and also improving and sharing information on the need to update the guidelines in cases where it hadn't been done, for example, on local level. The steps following then the pilot survey in ECDC and EU level, these indicators were included in our surveillance protocols and official 2017 onwards, and then the data collection actually slowly started in 2017, 18, and 19 data. And the first of these data were reported already for 2017, and then 2018, 19 more countries have started implementing the collection of these indicator data. But unfortunately for the 2019 surveillance data, it has really only been partially provided so far due to the current COVID-19 crisis. And to allow the data collection, ECDC continues to provide support for countries that want to establish or improve their national surveillance networks. Also for these, using these structural process indicators, we have a software tool for the data collection, and then we have decided to allow and promote shorter data collection periods if it's more feasible for certain countries to do like periodical surveillance. There's a quick acknowledgements for the SSI pilot survey group and my colleagues from ECDC. Thank you.
Thank you so much for this presentation. Since I see that have like both the presenter from the CDC, have a question from both Dominique Monet and Tommy. Do you believe that the recent European Commission proposal on the European Health Union could have an impact also on this issue that we're discussing today? Then also on prevention of surgical site infection? I don't know who prefer to reply. Just one sec. Okay. Yes, please.
I will reply first. Well, risk management, which is with prevention and the control of the infection, is still the responsibility of a member state. So we can support as much as we can, and that's what we're trying to do. And what Tommy presented is the next step. We know that there are difficulties on, I would say, local interpretation of the European standard definitions, but for reporting on those 6 indicators, there should be less variations because they're tangible things and there should not be an interpretation. So I think we should, since it's feasible, and I think more and more member states would go into this reporting, then we should make a difference this way. But in the end, prevention and control will be the responsibility of the member state, each individual hospital, each individual ward, and we're back in the debate that we had earlier this afternoon. So many things to do. In the end, you want an health department who's a role model and good interactions between people at whatever level in that ward, so the procedures are respected. But we have no action about this. Do you want to add something, Tommy?
No, not necessarily much. That of course also the surveillance activities then where we can support, but then the implementation of the surveillance is actually countries who do that and then should provide data for us. But that's all.
Okay.
So our strategy has been to provide tools that are as simple as possible, including tools that can be locally to promote this type of surveillance.
Thank you so much. Thank you. I don't know if any other speakers? Yes, please.
Yes, thank you very much. I have a couple of points that I would like to raise. Now, one thing is how to really get reliable data. As Paul Garissis has pointed out very elegantly, when we look at how not only the number of outpatient procedures are rising, but also there is a reduction in length of stay, it may be difficult to capture really the surgical site infections. They may occur after the patient has left the hospital, and they may occur in patients who never even stay overnight in the hospital. So this is one thing. And I think this is extremely important, because what Benedetta Allegranzi has mentioned is when we need an effective PDAC cycle to act, we need data. This has to be data-driven. One point I raised earlier is risk adjustment, and I have not really seen anybody presenting a tool for risk adjustment for SSI. And coming to the last point that was, I think, mentioned, yes, sorry, that was by Dr. Monet, thank you very much. Regarding the responsibility, now what we've seen before with the workflow of how to address the issue of SSI, I think it became apparent that the surgeon has a significant role, because when we define SSIs as those that occur after the knife has entered the skin, then the responsibility is with the surgeon. This does not mean to belittle the efforts and responsibilities of all those who act around the patient, and also the patient's own responsibility, e.g. stopping smoking before and after all these things. This does not belittle this at all, but when it comes to the central role of the surgeon, who does the indication for surgery, who does the surgery itself, and who's also responsible for care after surgery, it is the surgeon who needs the feedback, because he or she will be the decisive factor. So if this goes to a ward level, where the head nurse is responsible, or this goes to, say, a governmental level or a community level, say with the alderman or whoever, I'm not sure whether we will be successful. So it's my strong belief that there should be responsibility and feedback to the responsible surgical team. So whether this is on a consultant or departmental basis, this is something one can argue about. But I think because the central role of the surgeon, he or she is the one who needs the feedback, and he or she is the one who will be held responsible ultimately. Thank you.
Thank you so much. I don't know if Paul wants to add something, and he saw that it was kind of agreeing.
No, I appreciate the Wolf comment. I have quite nothing to add. Perhaps I prefer now to say she's an E concerning the surgeons, because you know that more and more women are now surgeons, and it's a very, very important fact, just a comment. But for the future, I really appreciate too the talk by Benedetta. The quality is a culture for medical doctors and all the teams. We have to improve the culture, the partnership to develop. And it was said by Pascal, we are not teaching enough at the beginning of initial formation to declare, to report, and to analyze our weakness as medical doctors or surgeons. So we have to develop this culture of quality of care, including infection, but not only infection, global perspectives, and we need data. I think that for the future, as was said by Wolf, we need a global perspective concerning the healthcare. And at this moment, I have to say that Europe must be the support to develop information available for all member states to develop quality culture concerning global healthcare. That for me is a more important point I have to say. Today I'm a medical doctor, and tomorrow I am a patient. and I need to know where it's possible to have the best healthcare, in which facility or with which team or surgeon or medical doctor. So information could be the key success to develop this quality culture.
Thank you so much. Benedetta, I believe you like to add something.
Well, I just would like to go back to my point of working together on data, in the sense that obviously this needs to happen at each level, like it was said. So local data to be discussed locally and understood locally, to identify among the many practices that are required to reduce SSI, which ones are particularly defective locally. This is super important, but I would like to bring back the discussion to European level and the interaction with my colleagues from ECDC and others, such as Health First Europe. I think it's a wish. At the moment, it seems crazy to talk about this, I suppose, because we are all totally absorbed by COVID. But I really hope that in the future, as soon as we are more available, and in this event today is something in this direction. I really wish we can go back to having cross organizations discussions where, for instance, ECDC provides, as usual, great insights through surveillance and monitoring data that they are able to continue to provide with high level of quality. And we and others, societies that are represented also in this group, are able to have discussion on interpreting this data and help discussions on what should we insist on in Europe, because even the interesting survey that Health First Europe undertook clearly showed that there are some recommendations that are quite harmonized across Europe, but there are others which are really not consistently implemented. So we should all together then insist on those ones and try to understand what we can do more to sensitize on the implementation of those recommendations, especially when they are particularly evidence-based. For instance, stopping antibiotic prophylaxis after surgery. So just to talk about one, which is very relevant for the next day's topic about AMR. So I really hope that we can break silos in the future, because as I said many times, does very interesting activities. I said, in Europe, we have the privilege to have providing so high quality and insightful data. We need to make more efforts, in my opinion, to interpret them and to help countries use this data. And then before I give you back the floor, I really wanted to thank Health First Europe, because this event today is really multidisciplinary, very inspirational and very informative. The report, as I said, it's excellent. And I think you were able to really combine, once again, data, information coming from the survey, but also a number of considerations about what's next, what should we do, what's wrong about implementation, and what can we do to improve it. So this report is really important, in my opinion, and we commit to disseminate it as much as possible. So thank you again.
Thank you so much, Benedetta. As Health First Europe, what we can say that we really hope to manage to break silos is what we have been advocated for the last more than 50 years, not only on infection prevention, but in general in healthcare. then because silos are not helpful in any sector. Then I don't know, please, there is a comment from Dr. Belkstein.
Yes, I would like to come to a point that I think it was Pascal Astanier who raised that regarding the patient's responsibility. And I was wondering, Paola Kruger, if she's still with us, whether this might be something that she could also envision from a patient's perspective, because I was quite surprised, but not surprised by Peter Sager's remark that sometimes one is surprised by the lack of hygiene of patients themselves, which we know this happens as frontline workers. But it's not only the personal hygiene, like taking a shower before coming to surgery, but also, say, not smoking, all these things. And when we talk about empowerment of patients, it's not only that the patient has obviously the right to question the surgeon's opinion on all this, but it's also responsibility, is also empowerment of the patient to make his own efforts towards the success of surgery. And this not only regards mobilization and all that, but also hygiene and preventive measures for SSI. So I think this would be very worthwhile to develop educational tools for patients as a handout. We've seen so many good things from WHO, etc., how the surgical workflow process works with interdisciplinary, but the patient's perspective and the patient's responsibility, I've missed a little bit so far.
Yes, I would like to reply to this observation. I totally agree with you, but this is one of the things we do also as U-Party. We train patients, and one of the things we try to do is to shift their minds, especially because we work with chronic patients. So this is an ideal case scenario to make them understand that they have to take responsibility in order to be able to have more choice. So if you want to decide with your physician which kind of therapy, of course, it's ideal for you because we think it's a joint decision, then you have to inform yourself and you have to have a proactive collaboration, no? Because you also have to take responsibility for being adherent to that, to the kind of care. So this is exactly the kind of shift we're trying to implement with patients and trying to train them. But I also agree that I think that any program, educational program aimed at patients should involve patients also in the creation. Because otherwise, if it's only designed by HCPs or institutions and it comes as a top-down approach, then it doesn't necessarily work with patients and you run the risk of losing many points that are fundamental for patients.
I would like to suggest something. Do you hear me? Yeah.
Yeah.
Yeah, about this point of the patient and the empowerment of the patient, as it's, I think it's my colleague Bechstein who just mentioned that there is more and more shorten of the length of stay for the surgical patient in hospital. So most of the time they are followed out of the hospital after the operation. And to diagnose surgical site infection, I think it's a problem for the system of following them, because we cannot know exactly if they don't go back to the hospital for instance, for clinic or visiting the surgeon after the operation. We don't know. We have no news. So we are losing them in terms of follow-up. And we are just now implementing, but with some difficulties because of the COVID-19 crisis, but I hope we are going to do it in the next year, an experimentation on the surveillance of the patient, so of the outpatient for ambulatory surgery, using a connected device. So the patient can, with some very precise criteria, report some symptoms that could be a surgical site infection. Of course, he cannot diagnose this, but he can just suspect and call his surgeon, or maybe be connected to the surgical staff if one or two or more criteria are present with this connection via internet. So I think it's an interesting way of enhancing the quality of the follow-up of the patient where they are outpatient in ambulatory care. So I don't know what if the surgeon present here know about that or have some experience to share, but I would like very interesting if it's the case. We don't.
Is there?
I think
no.
Dr. Bechstein is talking. That's...
Yeah, but okay.
Sorry, I was listening, but urgent call.
Okay, sorry.
Okay, then, I mean, if we don't have any other additional comments, probably we can draw the conclusion. Please.
I have used one figure that was also heard by some, and this is regarding the picture of Sisyphus, who's rolling up this big rock every day. I've been doing this in the field for about 30 years plus. The rock has been changing. Sometimes I had the impression it got bigger. But for those French speakers who know and may remember Camus, whether it's from school or university, il faut imaginer Sisyphe heureux. That's what Camus said. And this is the mindset. So I think despite all the difficulties that we have to encounter, I derive great satisfaction from what I do every day. And this is one of the challenges. And always I get new students coming in, new surgeons, female more than male today. But we all have to work together to do this, even if we have the impression every day the rock comes falling back and we have to push it up again. Thank you.
Thank you so much. I have one question for you all, let's say, from the audience. And you address, do you recommend for hospital to measure whether their individual implementation strategy was successful unless the decrease of surgical site infection? Which soft and hard factor do you recommend to evaluate? Then really moving to a single hospital, how we can really implement, measure the success of an infection prevention strategy.
Should I take that one?
Yes, please.
Go to the ECDC website. You will have a standardized protocol. It has been validated. You will have those indicators of prevention of SSI. Once you've achieved your results, and to reply to you, Dr. Bechstein, this includes a separation between post-discharge surveillance and in-hospital. We're using the index devised by CDC for sorting out risk between ASS score, wound class, and duration. So there's some standardization. And then they will be able to start benchmarking themselves with one database. When this is done, I'm sure they would like to liaise with those networks in their country, with peers, but the tools are there.
Thank you. Thank you. Thank you for your answer. Then is there any other comment or we can go toward the closing remarks? Then, first of all, thank you so much for all your really interesting presentation. For us, this one was really the first step of a longer process because we will not stop to work on prevention of surgical site infection. In the report that we are launching right now is online, basically we also put together some policy recommendation because we know that when we speak about prevention of surgical site infection, is not all about what doctors can do in the hospital, but what is happening at the management level, at the political level, and so on. Then for us, in terms of European Union, we'd like to call for an European framework on infection prevention. and really with one part dedicated to healthcare-associated infection. Also, we really believe that we don't need the new guidelines, as I think everyone agrees, but we need to make sure that we improve adherence to the guidelines that we have, and we need harmonization in terms of guidelines at the European level, and why not, at the global level in the perfect future. Also, one of our call is dedicated to the ECDC. We really hope to expand the power of the ECDC in the near future. Then we really look forward for this moment. And then we also point the key role of education. It will be great what we discussed today about the curriculum for healthcare professionals to be not just a national one, but an European one. And this will facilitate also the movement and the exchange of best practices. Then really, thank you so much for your contribution, and we will be in contact again in the future. Thank you so much. Thank you. Bye.
Thank you for organizing this.
Bye. Bye.
This evening. Bye.
Thank you.
Lilian, nice to see you.
Nice to see you too. I know. Such a fantastic talk. Thank you very much.
Thank you, Lilian.
Thank you so
I
much.
look forward to catching up.
Take care.
And thank you, Melina.
Thank you everyone.
Okay, bye.
Bye.
Take care.
Bye.
Bye.